Ay, matanda niya yun.
Ato po kay kanaya ini yang
Okay.
matam ina play ba
Mm.
in case mut khajuna
Mm.
sidang na kaya ke mar ko ngam ko tan ping ina ba sidang mo si tholo ko dili sa ni ngam ko yan mo lai ni ai ka
Hujitay ni ko kung mahiji ko. Kaya. Hawal ka ito. Good morning.
Good morning, sir.
Today we are going to discuss on the benign prostatic hyperplasia. Okay, urology class. So we'll start. So first we have to know the anatomy of the prostate. Prostate gland is located just below the urinary bladder. So it is a walnut-shaped gland that forms part of the male reproductive system. It surrounds the urethra, the tube that carries urine from bladder out of the body. Okay. So the prostate also has certain functions in the body as a part of the male urogenital organ. It secretes semen, which carries sperm. Sperm comes from the testes, but the major amount of the seminal fluid comes from the prostate and the seminal vesicle. So during orgasm, the prostate muscle contracts and propels ejaculate out of the penis. As we all know, the size of prostate enlarges microscopically since the age of 40. Half of all men over the age of 60 will develop an enlarged prostate. So by 80%, by 80 years of age, all men will have, 80% of the male will have uh, some sort of prostatic symptoms because of benign prostatic hypertrophy. But only 25% of men as at 80 will be receiving BPH treatment. So all men think that this is part of aging process, so they hardly consult the doctors for the symptoms. So what is BPH? Benign prostatic hyperplasia. So this is the hyperplasia, and that is the increase in the number of the prostatic cells, both the glandular as well as the stromal cells, thereby increasing the size of the prostate. So this is not hypertrophy, but it is hyperplasia, increase in the number of cells, and it affects mainly the transition zone of the prostate. So the prostate has got different zones: the peripheral zone, transition zone, central zone, anterior fibromuscular zone. So this classification of the prostate into different zones was started by McNeil. So the BPH affects mainly the transitional zone of the prostate. So when the transition zone enlarges, it compresses the urethra from side to side. So what causes BPH? It is part of the natural aging process, as I have mentioned already, and it cannot be prevented, but it can be treated. So before we go into the clinical features of this, we have to know what is LUTS, lower urinary tract symptoms. So lower urinary symptoms can be classified into two broad groups. Two groups. That is, first is the voiding symptoms, also called the obstructive symptoms, and the second group is storage symptoms, or irritative or feeling. So the voiding symptoms or the obstructive symptoms include hesitancy, weak stream, straining to pass urine, prolonged maturation, feeling of incomplete bladder emptying at the end of maturation, and urinary retention, which can be acute retention or chronic retention, which we will delve in detail later. The storage symptoms includes urgency, frequency, nocturia, urge incontinence. So hesitancy means patient wants to pass urine, and when he goes to the toilet, he has to wait for some time for urine to start the maturation. Okay, that is hesitancy. He has a desire to pass urine, but he cannot. He has to wait for some time. Weak stream. So these are all because of the obstruction. Okay, and storage symptoms or irritative. So this is due to the irritation of the bladder, especially the trigone of the bladder and the prostatic urethra. So urgency means patient has the intense desire to pass urine. Yeah, that is urgency. And frequency means increase in the number of maturation. Nocturia, so frequency is daytime, increase in the number of urination, and nocturia is increase frequency at night. So 1 to 2 times per night is normal, but if it is more than two and it affects the sleep pattern of the patient, then it is called nocturia. Urge incontinence. Patient has intense desire to pass urine and he can't hold it. It will end with incontinence. Okay, and you have to know that Lutz is not specific to BPH. So not everyone with Lutz has BPH, and not everyone with BPH has Lutz. That means there are other causes of Lutz other than BPH. It can be carcinoma prostate, it can be urinary tract infection, cystitis, urethritis. So Lutz is not specific to BPH. And the reverse is all patients who have BPH, they all do not have Lutz. Only majority of the patients will have Lutz, but not everyone will have Lutz, even if they have big prostate. So how will we diagnose BPH? First is assessment of the symptoms. So we have different symptom score. The most widely used is International Prostate Symptom Score, and it is based on a survey and questionnaire developed by the American Urological Association. It has got 7 questions about the severity symptoms. Total score is 0 to, if it is the total score is 35. Okay, so if the score is 0 to 7, it is mild. If it is 8 to 19, it is moderate, and above that is severe. And the 8th question included in this IPSS is the quality of life. Okay, does it affect the quality of life? That is also uh, very important from the perspective, patient's perspective. And next we have the digital rectal examination. Once you have taken the history about the symptoms, next is the physical examination. So digital rectal examination is important. All patients who have Lutz, they have to undergo digital rectal examination. It will tell you about the size of the prostate, even if it is inaccurate, but it will give you a rough idea whether the prostate is enlarged or not. So in DRE, the different points that we have to see are size of the prostate, the consistency of the prostate, whether it is firm, soft, or hard. If it is hard, it is suggestive of malignancy. If it is firm, then it is BPH. And if it is soft, it can be because of the prostatic abscess. So we have to diagnose this clinically, and we have to see the median sulcus, whether the median sulcus between the two lobes of the prostate, between the two lateral lobes of the prostate, the sulcus can be felt or not. In malignancy, the sulcus is not felt, but in BPH and in normal prostate, the sulcus can be felt. The median sulcus of the prostate can be felt. Then next is tenderness. In BPH, it is not tender, but if it is prostatitis, that is inflammation of the prostate, then patient will have pain or tenderness when you press the prostate gland with your finger. Patient will have pain. Next is ultrasonography. So we will see the kidney, the condition of the kidney, ureter, urinary bladder, and prostate. So we will know the exact size of the prostate by transabdominal ultrasonography. So normally the adult prostate size is 22 gram or 22 cubic centimeter or 22 milliliter. If it is more than that, then the size is increased. We have different gradings, ultrasound grading, grade 1, 2, 3. If it is below 50 cc or 50 gram, it is grade 1. 50 to 75 is grade 2, 75 to 100 is grade 3, above 100 is grade 4. And in ultrasound, we also will come to know about the PVR, that is the post void residual urine volume. So at the end of the ultrasound, you ask the patient to void urine and come again and see the bladder, the amount of urine left inside the bladder at the end of maturation. Normally, it should be minimal or uh, completely empty, but if there is post void residue, significant post void residue, then the intervention is required for the enlarged prostate. Urodynamic analysis, the mainly the uroflowmetry is required to do in BPH. In certain conditions, we need to know about the pressure studies of the urinary bladder. But if you know about the flow curve, that is sufficient for most of the cases of BPH. The Qmax, that is the maximum flow rate of urine, it should be at least 15 ml per second. Okay, so this is normal. 10 to 15 ml per second is uh, borderline, and if it is less than 10 ml per second in the maximum flow, then it is suggestive of obstructed flow. Then we have the prostate specific antigen. This is mainly a tumor marker for the prostate cancer, but in BPH it has high correlation between PSA and the prostate volume, specifically transitional zone volume. And we can do this to rule out prostate cancer also. The men who have large prostates, even if they are benign, they have higher PSA levels. And PSA is a predictor of disease progression and screening tool for carcinoma prostate, as I have mentioned. As PSA values tend to increase with increasing prostate volume and increasing age, PHA may be used as a prognostic marker for BPH. And the BPH also interferes with the sexual life of the individual. So you see in this pictogram sexual activity decreasing with age as well as with age. So if they have high lutes, they have uh, less uh, active in their sexual life. And next question is, when should BPH be treated? Suppose if you find incidental finding of enlarged prostate in ultrasound, are you going to treat that patient? For those patients who have symptoms with enlarged prostate, are you going to treat them? So BPH needs to be treated only if, so these are the indications, symptoms are very severe enough to bother the patient and affect his quality of life. And second is BPH related complications. So the patient has BPH along with complications, then you need to intervene. So the complications can be urinary tract obstruction, which can be acute or acute and chronic obstruction. Second is bladder diverticulum. Next is the chronic kidney disease because of the obstruction. Patient can have obstructive nephropathy, bilateral gross hydronephrosis with raised urea and serum creatinine. In those cases, you need to treat. And those patients who develop recurrent urinary tract infection because of BPH, as well as vesical calculus, that is the bladder stones. So these are some of the indications to intervene these patients. So choosing the right treatment, we have different treatment options. So to select the best treatment to the patient, we have to consider the risks, benefits, and effectiveness of each treatment, and also consider the outcome and lifestyle needs. First is watchful waiting, means you don't give any medicine, you don't do any surgery on these patients, but you have to see them. Okay, watchful waiting. Whether any symptom severity or complications develop, so you have to follow up these patients. Then we have medications. In certain patients we give medicines for BPH. And in the third option that we have is the surgical approaches. We have open surgery in the olden days. Nowadays we have the endoscopic treatment, that is TURP, which is transurethral resection of the prostate, where you insert a scope inside the urethra and resect the prostate bit by bit. Prostatic tips will come out, and then you will be able to reduce the size of the prostate, which is causing obstruction to the outflow. Then we have minimally invasive techniques nowadays, using different kinds of energies like lasers. Laser energy we have for prostate, different kinds of laser energies. We have holmium yak laser and green light laser or KTP laser. Okay, KTP stands for potassium, titanium, and the uh, potassium titanyl phosphate laser, KTP laser. And we have green light laser, we have thulium laser. So different energies in the form of lasers have come up for prostate disease. Watchful waiting is for patients with mild symptoms. You have to follow up these patients 1 to 2 times yearly, and you offer suggestions that help reduce symptoms, like avoid certain foods like caffeine and alcohol, avoid decongestants and antihistamines if they are taking for some other reasons. And we have, for the medications, we have first line of defense against bothersome urinary symptoms. We have two major types: alpha blockers and the 5 alpha reductase inhibitors. Alpha blockers, the action is it relaxes the smooth muscle of the prostate and provide a larger urethral opening. So the smooth muscles are there in the prostate as well as in the urethra. So when you give these alpha blockers, it will relax these smooth muscles so that patient can pass urine without much obstruction. And another group of drugs is 5 alpha reductase inhibitors. It actually shrinks the prostate gland. The benefits of medications are it is convenient. There is no loss of work time as patient can take it and they don't have to take rest for that. If you compare with surgery, they have to take leave from their work and then uh, they have to take rest after the surgery also. And the medication has very minimal risks. The disadvantages are drug interactions if they are this since this disease affects the older age group, they are taking other medicines for the heart or for diabetes or other diseases. So when you take these, you are adding a pill burden to the patient, so they can have drug interactions. And it must be taken every day. It manages the problem instead of fixing it. Okay. The possible side effects are impotence, dizziness, headache, fatigue, loss of sexual drive. These are the side effects of the different medicines. So alpha adrenergic blockers, the you have to know that the prostatic smooth muscle tone is mediated via alpha 1 adrenergic receptor. So blockage of the receptor leads to improvement of flow rate and the lower urinary tract symptoms. Central alpha receptors and the effect of agents on these receptors likely play an additional role. So the density of these receptors also changes also with the prostate size as well as the age of the patient. We have different kinds of alpha adrenergic receptors, alpha 1 adrenergic receptor subtypes A, B, and D. So these are distributed in bladder, in the trigone, the prostatic urethra, as well as in the prostate gland itself. So localization of the alpha 1 adrenergic receptors, alpha 1A, 1A, 1B, 1D are located in the prostate, smooth muscle, in the blood vessels, vasoconstrictor tone, as well as in the bladder. And we have different alpha 1L also. Whether it is prostatic selective or not, it's not yet understood. And we have alpha 2 receptor also. Alpha 2 receptor, which is taking part in norepinephrine reuptake. So this is not important for the prostate, but alpha 1 subtypes are important. 1B and 1D are important for the BPH treatment. Alpha blockers, broadly, they are non-selective. We are divided into non-selective, short-acting, selective alpha 1 blocker, long-acting, selective alpha 1 blocker, and long-acting selective alpha 1 subtypes. So these were used in the olden days, but nowadays we use only this for BPH. Tamsulosin, alfuzosin, sustain release. So we'll discuss in this detail. All currently available alpha-1 blockers induce fast improvement in loops and flow rate parameters with similar efficacy. They are all well tolerated. However, the adverse event spectrum differs between the agents. So, this olden days they use this terazosin, doxazosin, and it produces more dizziness, fatigue, and asthenia. So, this is not used nowadays. Tamsulosin induces more ejaculatory disturbance. So, because of the bladder neck opening because of the smooth muscle relaxation, the during ejaculation, instead of propelling forward in the urethra, it goes back. The semen goes back into the bladder. So this is retrograde ejaculation. So this is not usually given in the younger age group, which are who are sexually active. But for sexually active in a male, alfuzosin is better in terms of ejaculatory disturbance. It causes less ejaculatory dysfunction. So alfuzosin is for sexually active individuals, but tamsulosin is for older age group. None of the alpha 1 blockers alter the urodynamic parameters, prostate volume, or serum PSA. So alpha 1 blocker has nothing to do with the urodynamic parameter except for the flow rate. The flow rate will improve, but it is not going to reduce the size of the prostate volume, or it's not going to affect the tumor marker, serum PSA. Okay. So the next class is 5 alpha reductase inhibitors. So prostatic differentiation and growth depend on androgenic stimulation. So the androgen has a great role. Okay, testosterone, which is the male hormone, is converted to dihydrotestosterone within the prostatic stromal and basal cell, facilitated by 5-alpha reductase enzyme. So the 5-alpha reductase inhibitors deprive the prostate of its testosterone support. So they are not getting the testosterone. So the growth of the prostatic stroma and basal cell is not happening. There are different types of alpha reductase inhibitors, type 1 and type 2. Type 1 is usually seen in skin and liver, whereas type 2 is seen in stromal basal cell of prostate, seminal vesicle inflammation. So the 5-alpha reductase inhibitor, which is important, is type 2 inhibitor. So the specific cells growth depends on the testosterone and its active form dihydrotestosterone, which produces growth factors and results in the growth of the prostatic cells. So there is unbalance of these cell apoptosis and the cell growth. So if the cell growth is more than the prostatic cells will undergo hyperplasia and the prostate gland will enlarge. So the high alpha reductase inhibitors will inhibit these and then uh, inhibit the cell growth. So the apoptosis will be more than the cell growth and finally it will lead to shrinkage of the prostate volume. So mode of action of the 5-alpha reductase inhibitor is it inhibits conversion of testosterone to dihydrotestosterone. So we have this finasteride and dutasteride. Finasteride is only type 2 5-alpha reductase inhibitor, but dutasteride has both type 1 and type 2 5-alpha reductase inhibitors. So this is a newer molecule. Dutasteride is a newer molecule. We use combination therapy of 5-alpha reductase inhibitors and alpha 1 blockers. If the prostate volume is below 30 and patient has symptoms, we give only 5 alpha. We give only alpha blockers, alpha 1 blockers like tamsulosin or alfuzosin. But if patient has both prostate enlargement more than 30 gram as well as the obstructive symptoms, then we use combination therapy because we need to reduce the size of the prostate, not only the smooth muscle relaxation, but also we need to reduce the size. That's why we use combined therapy. So high alpha reductase inhibitor will arrest disease progression, whereas Alpha blockers rapidly relieve symptoms by relaxing the smooth muscles. So it relaxes the smooth muscle, bladder neck, and prostatic capsule, thereby improving symptoms and flow rate, relieving obstruction. Alpha blocker relax the smooth muscle of bladder neck. Okay, so the high alpha reductase reduce the action of androgen in the prostate, inducing apoptosis, atrophy, shrinkage of prostate, improve symptoms, relieve obstruction, prevent acute urinary retention, and prostate surgery. So coming to the surgical treatment, we have the office-based treatment for day case surgeries like TUMP, TUNA, WIT, but the gold standard is TURP, which is transurethral resection of prostate, and we have different techniques also. TUIP means transurethral incision of prostate. Then open surgery, we do prostatectomy. Open surgery, we have three techniques. One is we open the bladder and insert our finger, enucleate the prostatic lobes, the lateral lobes of the prostate, and the median lobe. That is called Freyer's prostatectomy. Freyer's transvesical. You have to go open the bladder and go from inside. That is the transvesical Freyer's prostatectomy. Next is Millins. Millins is you open the abdomen in the suprapubic region, and then in these you don't open the bladder, but you go behind the pubic bone and then find out the prostate gland, open the capsule, and you enucleate the gland. So that is called Millins. So Freyers and Millins are quite common, and in the olden days people used to do prostatectomy transperineally. It is called Young's, Younz, Young's prostatectomy. Nowadays it is not done because of increased morbidity. So we have three open techniques: transurethral vaporization of prostate, and then you can embolize the uh, prostatic artery. Then people used to have those who are not fit for surgery, they put prostatic stents to dilate the prostatic urethra. So just remember TURP, which is a gold standard, and those open surgery techniques, and lasers. Lasers, we have holmium laser, holmium yak laser, KTP laser, green light laser, and the thulium laser. Indications of surgical intervention are acute urinary retention, gross hematuria. Why hematuria happens? It can be because of cystitis, or it can be because of rupture of the vesical piles. Rupture of the vesical piles. Vesical piles are the dilated veins, dilated and tortuous veins around the bladder neck. Okay, because of BPH. So sometimes these vesicle piles, which are very thin wall, they can rupture anytime and cause gross hematuria. In those situations, you have to do emergency surgery. Then patient has frequent UTI, then you have to do surgery. Patient has vesicle stone, you have to remove the stone and treat the prostate also surgically. Or patient develops hydronephrosis or renal function deterioration or CKD, that is chronic kidney disease, then you have to do surgery. And patient has obstruction with IPSs more than 8, prostate size, okay, significant residual urine volume. In those cases, you have to intervene surgically. So conventional TURP and open simple prostatectomy. So in benign disease, since this BPH is a benign disease, you do prostatectomy, but it is simple. Why simple? Because you are not removing the whole prostate. You are leaving the lateral lobes, the which is called the compressed lateral lobes of the prostate. which forms the surgical capsule of the prostate, is left behind. So you are removing only the nodular glands. So transitional zone, central zone you are removing, but you are leaving behind the peripheral zone of the prostate, which forms the surgical capsule. So you are leaving behind that. That's why it is called simple prostatectomy. So even if you have done simple prostatectomy, patient still has a chance to develop prostate cancer later on because he has got peripheral zone intact. So the CA prostate can develop from the peripheral zone, usually from the peripheral zone, but BPH develops from the transitional zone. So technique of TURP, this is the resectoscope. You can see here with a loop electrode. Loop electrode will resect the prostate gland and it will remove the tissues bit by bit in the form of the prostatic chips. It uses an electrical energy to surgically cut and remove excess prostate tissue. It is effective in relieving symptoms and restoring urine flow. So this is the gold standard. So there will be 80 to 90% obstructive symptom improvement and 30% irritative symptom improvement. Mortality is quite low, 0.2%. The benefits widely available, it is widely available nowadays and it is quite effective and the effect is quite long lasting. Disadvantages are greater risk of side effects and complications like bleeding, perforation, injury to bladder, and stricture urethra. These are the complications which can develop. And clot retention. And usually patient requires 1 to 4 days hospital stay and catheter has to remain for maximum 3 days. Recovery time is around 4 to 6 weeks recovery time. The complications of URP can be immediate or late complication. Immediate are bleeding, as I've mentioned, bleeding, capsular perforation with fluid extravasation, TUR syndrome. TUR syndrome is due to dilutional hyponatremia. So you can't keep on resecting the prostate gland more than 90 minutes. So you have to complete your resection within 90 minutes. If you go beyond that, because of the fluid absorption in the vascular system from these venous sinuses in the prostate, there will be loss of fluid accumulation in the circulatory system. So it will lead to dilution of the blood and causes dilutional hyponatremia. So it is quite fatal. The signs and symptoms are there. You have to uh, identify or diagnose it intraoperative if patient develops TUR syndrome during the surgery. So they usually complain of restlessness, uh, then hallucinations, even blindness can happen, loss of consciousness. Patient can have tachycardia, hypertension. Okay, so these are the features of TUR syndrome. The treatment is the best is to avoid it. How will you avoid? You have to avoid by completing your surgery. Resection time should be limited to 90 minutes, 1.5 hours. Another is reducing the height of the irrigation fluid, which is used in TUR syndrome. In TURP is glycine, 4% glycine solution. So if you increase the height of the uh, glycine solution, the risk is more. So you have to optimize it. The ideal height is 60 centimeter from the pubic symphysis. So if you increase the height, PUR will happen quite uh, early. But if you keep it at optimum height of 60 centimeter from the pubic symphysis, then you can resect it till 90 minutes. Number three is nowadays we have the lasers. So laser use normal saline instead of glycine. So when you use normal saline, there is no risk of TUR syndrome. Okay, there is no risk of dilutional hyponatremia. So you can prevent it by using newer energy like laser, or we have nowadays TURP with the bipolar energy. The conventional one is monopolar energy. So you use non-isotonic or non-conductive fluid, which is glycine. But if you use bipolar energy, you can use normal saline as your irrigating fluid. So in that case, we don't have to worry about your syndrome. The lead complications include the urethral stricture, bladder neck contracture, retrograde ejaculation, impotence, and incontinence. Incontinence is quite rare, but impotence and retrograde ejaculation can happen. So you have to explain the patient before you proceed for surgery. They have to understand all the complications of this procedure. If the prostate is too large, like 100 gram, 200 gram, then doing PRP is a little bit risky and difficult, and the other alternative treatment is open simple prostatectomy, as we have mentioned here, either Freyer or Millin's method. And if patient has bladder diverticulum, vesicle stone, then you have to do open surgery. Okay, for the prostate also, so that you can handle the two conditions altogether in a single setting. Like bladder diverticulum, you can or diverticulectomy you can do. Vesicle stone, you can remove it by doing surgery. At the same time, you treat the prostate by doing prostatectomy. So this is what I have explained you about the minimally invasive therapy. We have different TUB, PT, TUI, prosthetic stents, microwave therapy, needle ablation tuna, vaporization of prostate, electrovaporization, photoselective vaporization of prostate, cryotherapy using liquid nitrogen, then transfer ethanol ablation of prostate. Okay, so the different modalities, but they are not very popular. The most popular is QRP and laser surgery. We have tulip, okay, VLAB, visual laser ablation of prostate, contact laser prostatectomy, interstitial laser coagulation, holmium laser resection. So this is it. With holmium laser, holmium yak laser, you can either resect or enucleate the prostate. Okay. Then we have high intensity focused ultrasound or HIFU. It started from uh, China, HIFU coagulation. Botulinum toxin A injection of the prostate. Okay, it will cause paralysis of the muscles, but these are not so commonly done. We have HOLAP, holmium laser enucleation of prostate versus URP. Different studies are there. They are quite good. We use KTP, potassium titanyl phosphate, that is KTP laser, okay, for prostate enucleation or vaporization. Bleeding is quite less. So this is the laser fiber you can see here. So it will produce laser energy. So it is inserted through the cystoscope, and then it will vaporize the prostate. You won't get any tissue. It will be all converted into vapor. Okay, and you won't see any bleeding with this surgery. It's quite good, but it is not quite available. How does PVP work? It vaporizes, removes the enlarged prostate. There is no bleeding. These are the advantages. So this is before surgery and this is at the end of surgery. Okay, so you can see that this is two lateral lobes of the prostatic urethra. This is the verumontanum, and here will be the bladder neck. This is the prostatic urethra. So it is obstructing the urine flow. Now after the laser therapy, the prostate is quite roomy. Prostatic urethra is roomy, and you can see the bladder very easily at the level of the verumontanum. So we have minimally invasive therapies for the treatment of PPH has the advantages such as less blood loss, less occurrence of hyponatremia, quicker recovery, reduced risk of urethral stricture. The disadvantage is long-lasting bladder irritation owing to higher temperature during therapy and possible longer catheterization period due to swelling of the prostate. It is still too early to make a definitive conclusion concerning the future role of these minimally invasive therapies for the treatment of BPH. Okay, so uh, okay, so next class we'll discuss about the carcinoma prostate. Okay,
Okay, sir.
okay, bye. Okay. N N N or the L. Oh, oh.